Next up, we have Dr. Marcelo Guimareas, and he is from a local institution. I'm going to ask him to tell us a little bit about himself, and we're fortunate to have him here today, as well as here in Charleston treating patients. So welcome.
I like to walk. Good morning, everyone. My name is Marcelo Guimareas. I'm a professor of surgery and radiology. I'm a vascular interventional radiologist. So probably some of you don't know what that is. He's a physician who performs minimally invasive surgery, right? So we use image guidance, so we can use fluoroscopy, a fancy X-ray, or you can use CT or ultrasound to perform procedures. The goal is to have one more tool or a couple of tools available for the multidisciplinary group of people that are treating patients with neuroendocrine tumor. So for me, it's a privilege to be here. I'd like to thank Roger Johns for being here. Roger, thank you. I'd like to thank Marianne and Bob as well. I think the service that you're providing to this community is outstanding. So I'll applaud what you're doing at the national level. And Roger at the local level. Just to give you an idea, Roger has been a huge advocate for this community and has sent patients to us to discuss cases, to give a second opinion. So our goal is to be available in the future in any way you can. So for me, it's a privilege to be here. So let's get started. I work at MUSC in Charleston, and this is the building, the structure that we work. This is MUSC campus. This is the Hollins Cancer Center. And this is, we work in both buildings, the actual Rio River Tower and in the main hospital. Before we get started, please raise your hand who is a patient here? Okay. Do you have any physicians here in addition to my colleagues? Any other physicians? What is your specialty? Physicians. Okay. Only have 2 physicians. Okay, 3 physicians. Okay, great. So for me, it's a privilege to share this table with you. I think we met years ago, Dr. Wang, in Whistler, in a meeting in Canada, when you were speaking about this, and I was speaking about local regional therapy. So it's a privilege to see you again. Yes, I do. Or try to have. So what's the goal when we think about metastatic disease, right? So it's important to understand, I mean, we want to provide the best care we can. We want to help the clinicians, the medical oncologists, the surgeons, when the patients don't have indication for other therapies. But our goal, every time I see a patient in clinic, and even if in my title it says vascular interventional radiologist, I'm not really a radiologist. It is important for you to understand. The specialists that you have locally, and you have interventional radiologists throughout the country, are physicians that are not seated in the dark, which that's the name of radiology, probably rings the bell in your brain. Well, that's a guy sitting in the dark reading films. That's not what I do. I don't do that at all. I'm all day long treating patients like a surgeon, and we are actually having patients in clinic as well, seeing patients in clinic. Okay, so that's what we do. We are much more like a surgeon than like a radiologist. So the goal every time you see a patient in clinic is to make sure that we can reach the outcome of having the patient disease-free. And every time, even if there's a patients with multiple lesions in the liver, and I have several patients with multiple liver lesions, patients come to us saying, and they heard from somebody else, I know my prognosis is bad, I know I don't have much chance, but I'd like to hear your opinion. And after going through the therapy, most of these patients, fortunately, months later or years later, are alive, and they don't have any disease. So I think there's a misconception in the community about how much interventional radiology can help. And I applaud what Marianne said before, that you need to fight for your best care, meaning that you need to have surveillance, you need to have follow-up, So those things that I'm going to discuss here, that's exactly, I agree with Marianne totally that you need to be followed and need to be, to try to look for alternatives in order to get this. Even if at the beginning, evaluated by somebody else, the outcome is not good or the prognosis is not good. So I want to start the conversation here with a very positive tone. There is good response for most people that are well treated. Okay? We have tools in our box to help you. That's the message I want to start with. In addition to surgery, in addition to chemotherapy, in addition to systemic therapy. It can be immunotherapy or targeted therapy intravenously. So the other goal is to have downstage. So in case there's a oligo disease, so just one large nodule, we can potentially downstage, make it smaller for potential resection. Sometimes it goes for resection. Sometimes we knock out the nodule totally to the point that does not need to go for resection. But that's one of the things we want to try to help our colleague surgeons as well. We want to try to prolong survival. So that's the goal ultimately. We want to provide quality of life and long-term survival. It doesn't make any sense for us to perform procedures in people who are advanced disease, for example, with bone mets, which are rare but can happen, and this patient is not going to have a survival. So we want to make sure that whatever we do, we want to have common sense and provide long-term survival with quality of life. And I was seeing here before, there are people with 20 years with a diagnosis of disease, right? So that's exactly what we want, to make sure that the patients can have a long-term survival with good quality of life. And of course, symptoms control. My clinical oncologist colleague here described very well the way we can have control of symptoms nowadays. And most of the patients that actually have liver disease, because of the metabolism of the hormones, if we treat the liver disease, most of the time we can control the symptoms. So that's important to keep in mind. So when we evaluate our patients in clinic, we want to have a physical exam, we want to have images and blood work, and all the blood work that you are already familiar with. I don't want to go into details about that. But what is important in my mind when I talk to a patient, evaluate a patient, is to make sure that patient has had the primary cancer, primary tumor identified or not. And that's critical because, as you probably know, most patients who had the primary tumor resected, and even if they have metastatic disease in the liver, that's going to be their best choice, the best outcome. So we need to try to identify what a tumor is. Sometimes it's not possible. Sometimes the tumor are in the small bowel and it's tough to resect. It's difficult to identify what it is. So that's when the nuclear medicine scan can help us to identify the primary tumor. So resection is important to have better long-term results. We need to understand if this patient underwent to other treatment, special chemotherapy can have toxicity of the liver. Is the patient a drinker? Some people don't know that 3 or 4 drinks a day is abuse of alcohol. And it's not unusual for us to have a patient who is in a situation like this that drinks a lot of alcohol. So a lot of alcohol with prior systemic chemotherapy that can affect the liver, plus what I'm going to do in the liver can be a bomb in the liver. So, message, if you have someone who, or yourself, or have someone who has liver disease, metastatic disease in the liver, and you are about to go for local regional therapy, that's another name to call what I do. Is vascular interventional radiology procedure, interventional radiology, local regional therapy, or liver-directed therapy. They are all synonyms, and I'll use them interchangeably, okay, throughout the talk. So if you are going to go for a procedure like with us, alcohol is not allowed. This is critical. In addition to that, we want to have labs, of course, to understand the liver function. The reason why I'm emphasizing that is because the only patient that died in my hands about 10 years ago was a patient who was not believing what we were saying, still drinking occasionally, and this patient had a major liver dysfunction. Occasionally, for him, was 1 pack of beer a day. It's not occasionally, right? It's a lot of alcohol. We need to discuss with the patient very frankly all their options. Can be surgery, can be chemotherapy, can be other alternatives that we have now. Fortunately, we have a lot in the pipeline. of additional therapies that are non-invasive. So what I do is invasive. I prefer to offer something that is less invasive. And of course, what's the patient's performance status? Performance status means if the patient is active, if you're playing golf, if you are helping the house, we're going for groceries, we want to know how active the patients are. That's very important because it gives us an idea how aggressive we can be, how much that patient will tolerate what we're going to do. And part of the liver test that we do, we want to know how is the liver reserve. So again, to make sure the patient can tolerate what we're going to perform. Is there any extrahepatic disease? So if the patient has extrahepatic disease, as was mentioned by my colleagues here before, we want to try to either associate systemic therapy plus what we can do in the liver, or depending on the amount of disease globally, I am going to back off and just go for systemic therapy. Okay? And is the tumor functional or non-functional? That's very important, depending on the symptoms that the patient has, and then that's going to guide us how aggressive we can be. So as we discussed before, there are several options today. Surgery should always be considered, especially related to the primary cancer. In the liver, there's debate. So some people prefer to go for surgery to resect if there's only oligo disease, so one nodule. But if there are more than one nodule, we tend to, at least in our institution, to use a couple of options. And the options that I can offer, my toolbox has a couple of things. One is blend embolization. It's also called TAE, so transarterial embolization, right? We'll talk about that, what that is in a second in detail. We have TARE, or radioembolization. So one use radiation delivered in the blood vessels. We do not block the blood vessels, just deliver by flow the beads. Blend embolization, we definitely mechanically block with a plug. There are different plugs available. We starve the tumor from blood supply. The tumor dies because there's no blood supply going to it. The mechanism of the radioembolization is radiation. Instead of coming radiation from outside, like the external beam radiation, we have radiation loaded inside. So imagine that you have small beads and drop in several tiny thousands, millions actually, of tiny little beads that are nuclear bombs, if you will. And those nuclear bombs are going to be directed by flow delivered into the tumor. The other tool we have is ablation. Ablation can be used, we can use microwave technology, or we can use radiofrequency technique. So either one of them is good, and I use both in different scenarios. But the concept of microwave is, if let's say that you have a steak, and I hope nobody cooks the steak in the microwave. I hope. But if you want to cook your steak in a microwave, you can put a steak inside the microwave, turn it on. And let's say you have a very thick steak. What's going to happen with that steak? It's going to cook from inside out, right? It's the same principle. The difference is we put a needle inside the patient, throw like a biopsy, under general anesthesia, generally, and then we cook the tumor, quote unquote, cook from inside out, an ablation zone that's going to be killing the tumor, and that's total death. In my hands, if the patient has a nodule, this is the best solution between the two. But I think that even better than the two together, not in neuroendocrine tumor, but in hepatocellular carcinoma, liver cancer, a little different disease here. If we have data enough to show that the combination of techniques, and I'll describe this in a minute, is the way to go. Combination of techniques means you block the blood supply of the cancer with an oil. The oil becomes very bright in a CAT scan, like contrast, and then we can burn that nodule right after. It can be day after, same day, or days later. So it's a combination of embolization and burning back to back. This has phenomenal results. It's better results if you compare to both individually when you compare in cancer, liver cancer, not in neuroendocrine tumor, but I used in analogy the results. External beam radiation is also an alternative, and systemic therapies that were discussed by my prior colleague here. So when we have a diagnosis and look at the amount of disease in this patient, right? This patient became a dear friend nowadays and look at the amount of disease it has in both sides of the liver. So we always like to have a good diagnostic CT or an MRI. And you can imagine how many times, and this is I'm trying to advocate for you now. You can imagine how many times in community hospitals we have misdiagnosed or bad scans, bad MRI, low quality CTs, underdiagnosing this amount of disease. If you don't have the right sequences, and for example, if you don't have a 4-phase liver CT, don't waste your time, at least for the beginning of the diagnosis, the beginning of your treatment, okay? And MRI sequences make a difference. Depending on the sequences that are selected, you might have a diagnosis, you might not have a diagnosis. So it's important to understand, and you need to advocate for yourself. Doctor, at the beginning of my follow-up, I want to have a 4-phase liver. Down the road, you can do whatever you want, but at the beginning at least. An MRI has to be the right sequences, okay? That can make a difference in your diagnosis. I've seen a lot of misunderstanding about how much disease the patient has, depending on the sequences that are used and depending on the amount of disease. So when we have a case like this is the same patient, right, that I showed. But I broke that CAT scan, and let's pretend that we have 3 different patients here. I want to guide you through my thought process. How can we define what therapy we're going to use among what I have? So if the patient has, for example, just a small peripheral lesion, that patient could be treated by surgery, resection, zip it, done. Or if you don't want to go for surgery, or the patient has high risk for, let's say, diabetic, unstable diabetes, has pulmonary disease, has COPD, has uncontrollable hypertension, bad coronary artery disease, so many other comorbidities, we can easily do this, we can treat this with an ablation. Okay? So this can be treated either surgery or by ablation. Simple. If the patient has disease in both sides of the liver, but let's say 2 nodules, we could do either chemoembolization, blend embolization, or we can do the combination of both that I told you before. And we can take care of those 2 nodules as well. We can go for liver resection both sides, right? And then if you have a large nodule or disease systemically, I prefer to use first the Y90 or radial embolization because it does not block the blood supply, followed by the blend embolization. Why? What's the data to support what I'm saying? 0 data. Sorry, I want to be honest. But there's some logic behind. The logic behind is the blend embolization blocks the blood supply. You put a plug there. If I put a plug in the vessel going to the cancer, and the cancer is going to recruit new vessels around, I lost the opportunity to deliver radiation first. And radiation does not block the blood supply. Is that clear? So that's why I prefer the strategy of delivering a nuclear bomb first, leave the doors open, the roads open, and if the tumor is still alive after 3 months, then we can perform blend embolization. Okay? So that's the strategy that we offer to our patients with that rationale. What's the data to support what I'm saying? No data, just 15 years and a little bit of white hair. Okay, so let's go into details for the ones who are not familiar with these techniques. So liver-directed therapy, the liver magnification view, we get access in the aorta, the red is the aorta, right? Bringing blood to the liver, and let's say that this is a metastasis. And like in this patient here, you can see multiple metastases all over the place. Left side, right side. So the goal of the blend embolization, just to make sure we understood this clearly, we want to deliver some beads. In our institution, we don't use beads at the first one. We use an oil called ethiodol or lipiodol. And the reason why I use the oil, I prefer a liquid embolic agent, liquid plug. That plug is going to be deep into the very small vessels of the cancer. And there is some papers, not in neuroendocrine tumor again, in liver cancer, that the more packed, the better the packing of oil inside a cancer, the better is the outcome. Basically, there's no more blood supply. It's just the whole cancer is filled with oil. That's why we use oil instead of beads, okay? There is some preliminary, there's at least one paper out there comparing blend embo versus chemo embo versus Y90, and the technique that we use has the better outcome. Okay? It's a paper from 2015. So, this is what we're trying to do. Whoops. I think you unplugged something. Or did I press anything wrong? No?
Oh, you got a blank slide.
Oh, I'm sorry. All right. So we have a catheter and the catheter delivered. You guys understood that. So access. Access is a big deal for us. You can get access when you do liver-directed therapy through the arteries. You can go through the patient's groin or the patient's wrist. And we studied this, and we did a randomized clinical trial to compare if the patients prefer wrist versus groin. And out of 5 patients, 4 prefer the wrist. And there's several reasons for it. Patient can walk right after the case. If the patient is obese, by the way, I don't know where the groin is, somewhere here. If the patient, with this type of scenario, we have to be careful, right? We don't want to be sticking the groin here with look at the amount of soft tissue. I'm trying to be nice. Soft tissue around the patient artery versus in the wrist. So for patients who are obese, we definitely go for the patient's wrist for obvious reasons. You don't have to be a doctor to understand that, right? Also, if the patient has some bleeding risk, a lot of patients that we take care are taking anticoagulation, they're taking aspirin, they're taking blood thinners for whatever reason. We do not need to stop those meds if they have radial access. And if the patient has also low platelets or high INR, liver dysfunction, we do not need to stop the give platelets or change give fresh frozen plasma to correct the INR either. And this is a patient, just to give an example, patient with a very low platelets, 30,000 platelets, INR was normal, and that's the total, totally okay, totally fine next day after we intervene. Let's talk about ablation now for a second. So the ablation, as I said before, we use microwave or radiofrequency, and the goal is to put a needle inside the cancer and burn that nodule. In this case here, you can see why I was talking about the oil. When we inject the oil in a CAT scan, this is a CAT scan exam, you can see the light bulb in your face, that's a nodule. If the nodule is hypervascular means there's a lot of blood supply, a lot of blood vessels going to it, we can inject the oil super selective, and when we scan, we have the margins beautifully light up for you. And margin is the best results for ablation is all about the margin. If you care about the margin, you are very OCD, meticulous like we are, to calculate the margins really well, the tumor is gone. Once this needle gets to 60 degrees Celsius, there's no alive cell anymore. Neither of the liver, neither of the cancer. It's dead. So that's why I like this technique so much, the combination, because I can inject the oil and I can see really well, clearly, the borders. So this is a preparation of the patient's wrist. This is the environment that we work. See the patient's arm comfortably open here. This procedure is performed under moderate sedation or general anesthesia. Moderate sedation, I think you understand. We give Versed and fentanyl, 2 drugs. One to make the patient calm down, relax, be a little sleepy. And the other drug is for pain, right? And this is the environment. We are doing a Y90, a radioembolization here, injecting the radiation from this box into the patient there. And we typically like to go through the patient's wrist. We do the access under ultrasound guidance. The radial artery is about 2 millimeters, between 1.6 and 2.2 for most people. 1.6 millimeter, that's tiny. But believe me, it's enough for us to get access and travel all the way down to the body and go to the liver. And that's the sheath, a small plastic tube. So there's no cut downs involved in what we do. So Lepiadol is the oil that we discussed. We get access in the patient's wrist. This is the left hand. We get access here, navigate all the way down to the aorta, and then our goal is to kill this tumor here. So we got access with the catheter. Then we go super selective using a microscopic catheter. We call microcatheter, a little thicker than a hair. And then we get access super selective. You can see the tube here. This has less than 1 millimeter in diameter, this catheter. And then the goal is, as you can see, they have a lot of contrast going to the cancer here. And this is after, no contrast at all. That's my endpoint. I don't want to see any more flow going there. Just pack it up oil in that tumor. And we might need more than one session. Some patients, depending on the size of the tumor, might need a second or third session to obtain tumor control. But using super selective catheterizations, putting the microcatheter as close to the face of the tumor, the vessel of the tumor, the better will be the outcome. And we're getting pretty good results in several cases with only one procedure we can control. So that's blend embolization, okay? Let's turn the page now and talk about radioembolization. So as I said before, the radioactive agent that we use is Yttrium 90. Yttrium 90 is loaded into these small, tiny little beads. The beads measure, just to give an idea, 8 to 20 microns. That's smaller than a sandstone. They are microscopic beads, but they are beautifully round beads like that. And the radiation, and if you go through a Y90 procedure, you will not be glowing at night when you go walk on the street, right? You're not going to be radiating everybody around you, okay? The radius activity is about 1 centimeter, 11 millimeters. Well, of course, for common sense, we do not recommend somebody who just had Y90 today sit next to a pregnant woman. Common sense. If you have a young child, don't have the child sit in your lap. But don't worry, you still can sleep with your wife or husband, okay? That's not an excuse for not to do that. And the activity of these beads are biological. There's an activity inherent to the radio pharmaceutical, which is about half-life is about 64 hours. But biological effect is 3 months. So that's why when we bring the patients back in 30 days after a procedure, a Y90, we do not discuss about outcome in that CAT scan and that MRI or CT in 30 days. 30 days is for us to have an idea if there's progression of the disease or if the patient has some response or not. We're really going to have a real response at 3 months. So before 3 months, do not worry about outcomes if you underwent Y90 infusion, okay? We need to wait for that time. And here's the way the mechanism is similar. We get access to the patient's wrist or patient's groin, put a microcatheter in the tumor. We try to be as selective as we can. In a case like this, it does not make any sense to go super selective because this patient has 12 metastases, 12 nodules. So then what we're going to do is a lobar, a diffuse infusion of Y90 in the whole lobe, okay? Not super selective like we would like to. This is, so talking about radioembolization, typically a 2 days procedure, and they are typically 1 week apart. Day one is the workup, we call. In the workup, we need to make sure we have a good mapping. So as you can see, the catheter is coming from above. We're injecting contrast. This is the liver area. And we see vessels going to the duodenum, to the pancreas, to the stomach. And we don't want to have the radiation, the real radiation, the Y90, injecting those organs. So in order to do that, we need to understand the anatomy really well. If I can be super selective in the, let's say there's a cancer over here, I'm not going to be blocking any other vessels going to the stomach or duodenum or pancreas because I'm far. But if I need to embolize more proximally to get the whole lobe, I definitely need to block those vessels to avoid side effects and to avoid complications. Okay? So that's day one procedures, the workup. We do a mapping, inject contrast. Also, we tend to plug the vessel, this vessel here. Not always, but we tend to put some coils, some plugs. So I'm blocking here any potential reflux of the beads to go to those organs. Because if I have the Y90, going to the stomach and duodenum, the patient can have ulcer or perforation. And it's one of the worst ulcers you can possibly have. Why is that? Because it takes how many months for the biological effect? 3 months. So you can take H2 blocker, whatever antacid you want to take, you are not going to get better for 3 months because the beads are going to be still active, okay? So in order to avoid that, we sometimes, not always, block this vessel. And then on the same day, the third thing you want to do, so one is mapping, understand the vessels. The second is to block the vessels if you need to. And the third thing you want to do is to inject a fake radiation. Fake radiation, there's no better term from my point of view for you to understand. We're going to inject something called technetium-99, and that's another radiotracer, another radiopharmaceutical agent that we're going to inject to simulate where I'm injecting from on the right, injecting from the left, if that radiation, fake radiation, is going to be stuck to the liver only. If I see that radiation going somewhere else, oops, I forgot to block something. Okay, that's a very important step of this procedure. Next, in the same day, hours after we finish this procedure, after we inject the fake radiation, we take the patient to a nuclear medicine scan. And then we're going to have check a SPECT, and the SPECT is going to show us, first of all, as you can see in this case, the majority of the radiation, the white is the radiation activity, okay, the uptake. We can see this is stuck to the liver only. That's exactly what we want. Also, we want to know if it's not active here, because if I see this brightness around somewhere, like in the duodenum on stomach, I cannot do the case. Second thing we want to know is the shunt. So what's the communication? How much of the radiation went to the lungs? If we have the Y90, the real radiation going to the lungs, the patient can die from pneumonitis, from inflammation. Okay? So we need to make sure that this shunt is less than 20%. If it's less than 13%, we go for full dose of Y90. If it's if the shunt, meaning the percentage between radiation here and there, if it's between 13% and 20%, we reduce the dose of Y90. And if it's above 20% shunt, it's a contraindication for Y90. Okay? Those are the numbers that we use on a daily basis. So after, we only confirm if the patient's a good candidate for Y90 after checking this scan. Before that, everything's just workup. And then we talk to the patient and say, okay, we're good to go. Then days later, typically a week later, we order the beads, we calculate the dose of Y90 to be injected, and then we can deliver selectively, or, like in this case, the whole lobe in 1 day, and I typically bring the patient back 30 days for the other lobe. We do not do both lobes at the same time. Why? Because we want to be more aggressive, quote unquote, positively aggressive, to deliver a larger dose to one lobe, see how the patient does, recovers from one, and then we can be more aggressive on the other side. If I do both lobes at the same time, the same day, I need to decrease my total dose. Thinking that the higher the dose, in theory of radiation, the better is going to be the outcome. Is that clear? So if you need to do bilateral infusion, we typically do one side 7 days later after the workup, and then 30 days after the first infusion. Is that clear? Good. So here's a real life case. Believe me, we don't work that fast. Okay? But this is just a case to show that we want to inject in Y90. And I wish I could stop a little bit here. I was with the hope that I could pause. But this is the day 2 when we are injecting basically Y90 in the liver. All the nodules you can see there, using a microcatheter there. I'm so sorry. I wish I could pause. Can you pause for a sec? It's okay, no worries. So also, something we've been doing at MUSC, and whatever you're going to find in the best cancer centers in the world, you're going to find at MUSC. I have the privilege to say that. And this is some of the fancy stuff that we have, which is rotation and geography. We do this all the time, and the goal we do this is not to over-radiate the patients, but is to see exactly what vessels are going to the cancer. So for example, after doing that spin, I can tell the system, I have a cancer in this area, this orange dot, show me all the vessels that are going to that cancer. It's a phenomenon. I don't know if you guys can appreciate that, but it's phenomenal technology, because then I can go super selective in this vessel here, in that vessel there, and only deliver either the oil or the radiation to those vessels and preserve the rest of the liver. Why? Because you want you guys to live for a long time. Okay? And then then after we inject the Y90, the real deal, the real radiation, we want to have another nuclear medicine scan to see if the radiation reached the target. So I confirm, no question, we delivered a nuclear bomb where we wanted to kill the tumor. This patient had a follow-up 3 months later. 3 months later, please stop there, if you can. Help me to stop. Hello? Thank you. We'll run again, don't worry. We'll run again. Okay, you can continue now. We'll run again, then I'll ask you to stop in a second, please. I want to show something very important. Get ready to stop in a second here. Stop there. Okay. This is 3 months later, okay? And this patient has, as you can see, some reduction of that large tumor that I showed you before, but there's some enhancement, we call ring enhancement. So there's contrast in the periphery. If this was at the 30 days follow-up, this can be cancer, residual cancer, or it can be inflammation around the cancer. Maybe the cancer is totally dead. It's just the body has inflammation around, kind of a decrease in the amount of dead tissue. But if I have this finding at 3 months, we maximized the work of Y90. So this patient, in this case, has residual disease. What can we do in our algorithm at MUSC? I'm going to offer to him bland embolization. Okay? And that's exactly what we did. So we offered bland embolization after 3 sessions. After 3 sessions of bland embolization, he trusted us, and here is the deal. This is 6 years later. This is a CAT scan from last year. This is from 2012. This is from 2018. Look at the amount of disease this patient had, and no evidence of disease 6 years later. This patient is in the room, by the way. So that's what we want to do. Can we obtain this type of outcome in everybody? No. But I prefer to use your terms, and I like your talk a lot, by the way. You use the term personalized medicine, right? Precision medicine. To me, that's the concept that we need to understand more and more. When I see physicians making a decision on a patient's life, that's 100%. That human being in front of me is 100%. But making a decision based on studies only, can be a randomized study, can be the best study in the world. You're not seeing a human being in front of you. You're seeing a number. So I think we need to make a decision, make our decisions. That's what we do at MUSC, based on my experience, discussion with the multidisciplinary approach, but above all, what can I do for that human being? Can I make an impact without being in algorithms, without being in the National Cancer Association algorithms? Should I do something else? If I believe that I can, I think I should do it. And fortunately, I have dozens of cases to show you what we've done to change the practice, not following the standard of care, and the patients are alive, walking, talking today. So, precision, precise medicine. I love that term. Okay, this is the setup for ablation. Whoops. All right, no worries. This is the ablation setup, a needle getting in the body, patient's body on the side, as you can see, similar to a biopsy. Just to show how we do. Again, margin is the most important thing.
Hey, you're fine.
I'm sorry. Margin is the most important thing. This is a liver, a real liver, explanted. You can see the tumor here. If I go and stick to the red, I'm going to leave tumor behind the periphery. We cannot let that happen. That's why the oil is so important. We want to make sure we cover all, make a bigger red here, like we did in this case. So you can see I'm killing here this part, then we push the needle to another part. Now, look at this needle placement. We have a total margin here, there, and there. So if you see the non-contrast CT, can you see where the cancer is? Can anybody say where the cancer is here? If you can, you are the best radiologist I've ever seen, ever met. So that's why we inject the oil. Clearly you can see this is the same patient, guys. Same patient. With the oil, you can see clearly where it is. All right? All about precision.
Okay, you're fine.
And this is the type of setup we have at MUSC that we can do in a single day. Single day, we can do the combination of both procedures. You can get the access in the groin, the wrist, and then on the same machine, not a CAT scan. Our fancy angiography suites nowadays can allow us to put a needle in and burn the tumor at the same time. So most patients will not have much symptoms after all of these procedures that I described, but about 40% of them can have pain, nausea, flu-like symptoms, and fever. It's important to know that radioembolization is the one that has the least amount of side effects. Radiation is good in that standpoint. Patients complain more of nausea and pain. But when you go for blend embolization and ablation, definitely the patients can have flu-like symptoms and fever as well. Fever does not mean infection, means inflammation after the tumor is getting dead. Potential complication is pretty rare. In our experience, in our database, we have less than 1% of complications. We can have gastritis and ulcer. That can happen. I had one patient that happened in the past. Infection, that can happen as well. That's why we give antibiotics, especially important in blend embolization. And for ablations, of course, as we stick the needle in the liver like a biopsy, there's a risk of bleeding, and there's also a risk of infection. To finish, radio access, I believe we're trying to build that at MUSC, the best practice. And from my standpoint, radio access is part of the best practices. All these procedures can be done as an outpatient nowadays. Patient can go home the same day. We are doing more and more the single-day technique that I described to you, the embolization followed by ablation. In this case, we're keeping the patient overnight for this case because it requires more in the procedure. We perform, I think it's part of the best practice to perform rotation angiography so you can be super selective. And of course, close surveillance in clinic. Let me skip this part. I'd just like to finalize saying that the survival of patients that are treated by us depends on multiple factors. K67, NSE, I mean several factors, and the amount of vascularization of the cancer, if it's hypervascular versus hypovascular. It's important to know that Y90 and TAE and blend embolization have a well-established role on the control of the neuroendocrine tumors. All the patients that we see in clinic are kept on octreotide despite the success of our procedure. And it's very important to work together with our colleagues to try to see what's the best way to treat our patients to have this type of thing. That's what we like. We like to have people alive, have enjoyable life, meaningful lives in the long term. Thank you.